Good afternoon, everyone. I welcome you all to this special occasion of the guest lecture, which is to be delivered by Dr. Suresh K. Mukherji, who is Professor of Radiology and Radiation Oncology, University of Illinois, and Robert Wood Johnson Medical School, Rutgers University. He is also faculty of Otolaryngology, Head and Neck Surgery, Michigan State University. He is also National Director of Head and Neck Radiology, ProScan Imaging at Bruce, and he is also a Bruce Bradley Fellow, the Leapfrog group. He has a lot of credit to his association with different universities and different capacities. In case we go through his traditional and non-traditional achievements, they are quite significant. He is past president of American Society of Head and Neck Radiology. He is Neuroradiology Division Director, University of Michigan. He is departmental chair for Michigan State University. He has published more than 500 scientific manuscripts, given more than 500 talks, and published near about 15 books. His current editorial position is in Neuroimaging Clinics, MR Clinics, and JCAT. He is also chair for Certificate of Need Commission, State of Michigan, Medical Advisory Group, National Alliance of Healthcare Purchasers. He is medical director, Economic Alliance of Michigan and Kentuckiana Health Collaboratives. He is also Chief Medical Officer, Michigan State University. He is a healthcare consultant, also involved in corporate medicine, and he is also 2023 Bruce Bradley Fellow at the Leapfrog Group. So we have the opportunity to have interaction with him. To initiate the proceeding, I request our Honorable Director to formally welcome. The topic on which he is going to deliver the talk includes, again, very interesting topic, which is the discussion in any healthcare setting and present-day scenario. Even the institute has established a state-of-art Center of Excellence in Artificial Intelligence, which is again a working group which has been constituted with the help of ministry. So the topic is artificial intelligence, challenges and opportunities for implementing this artificial intelligence in clinical practice. So may I request Dr. Suresh K. Mukherji to please deliver the talk.
First of all, thank you very much for this honor. I didn't realize this was going to be such a formal process. Director, thank you for being here. Just a couple of introductory comments. So I was born in England in the last century. I hate to say that. My father was from Calcutta, and my mother was from Karachi before partition. So although I've never lived in India, I've always had this proclivity or sense of duty to the homeland to try to help as many Indians as we can during my time. And so I first became familiar with All India when my parents were growing up, because I don't think they were smart enough to get into here. I certainly wasn't. So for me to be here really is a tribute to them. So, I want to thank you for having me. Second, I want to thank you as an institute. I think those that know me know that I've had numerous people from AIIMS that I've trained back in the United States, and those people have gone on to just do wonderful things. And, as a mentor, it's you get a lot of pleasure when you see the talent that you help bring over to the United States and give them opportunities, and eventually they eclipse what you've accomplished as an individual, as myself. And I really attribute that to the training and the leadership and the culture that you've developed at AIIMS over the last century. So, I first, I know you've thanked me, but I really want to thank you for everything. And also, I hear the radiology here is doing wonderful things. I'm a neuroradiologist, so I've heard some of the strategic planning that's going on and some of the opportunities. So, I congratulate the director and the organization and all that are associated with this for understanding that one of the big opportunities in the future is neuroimaging. I'm a little biased when I say that, but I think in this room we can get a lot of agreement. So thank you very much for everything. I think I can't close this though, so there we go. Okay, great, okay. So what I'm going to do over the next 45 minutes or so is that I'm going to be giving this talk on artificial intelligence, and really it's the challenges and the opportunities in clinical adoption. So artificial intelligence has really been around for the last 40 years, and I think, if there are people that are really coders and really understand AI, you probably know much more about the physics than I do. But from my standpoint, I have a bit of a traditional and non-traditional background because I have the traditional things that you do in academic radiology, but because of my interest in healthcare policy and also in the United States, we have to say the least, we have a very unique healthcare system. And if anyone can, I haven't figured it out yet. I was born in the last century. I'm now over 60. I hate to admit that, but I've been in the system for a long time, and I still haven't figured it out. So let's just say it's very, very complex. But suffice it to say, it's a very unique system. And so what I'm going to do over the next few minutes is just talk about some of the challenges and opportunities of artificial intelligence and actually integrated into clinical practice. And I will be focusing on radiology, but I think some of the principles that I'll be discussing will be applicable to many of in the audience. I have the directors of pediatric surgery. I met someone that's in physical medicine and so on and so forth. So what I'm going to do is give you this, this was a great video that was created by Jeff Hinton, and I've never met Jeff Hinton. He's from the University of Toronto, but he really is a major thought leader in artificial intelligence. And this was created back in 2016. And so this was machine learning and the market for intelligence. And I hope you can hear this because this really led to some of the promise of artificial intelligence, but I would also argue some of the hysteria of artificial intelligence, especially as it pertains to radiology. So this is just about a minute video, so hopefully you can hear this, and if you can't, let me know. Oops, sorry about that. Let's see. Let's see if I can.
Jeff, perhaps a similar question, if you may. What do you think is the most exciting work to done? Okay, so, let me start by just saying a few things that seem obvious. I think if you work as a radiologist, you're like the coyote that's already over the edge of the cliff.
So there'll be lots of that. And I think of that now as business as usual. Take any old problem where you have to predict something and you have a lot of data. And deep learning is probably going to make it work better than existing techniques.
So I thought that was a bit controversial when that was said. This was done in 2016. And unfortunately, what ended up happening was that comments like that gained a lot of traction. In fact, there were comments by even President Obama at the time suggesting that our field as radiologists would be obsolete. So like I said, I was born in the last century. I trained in the last century. I did my residency. I started actually in 1988. And there have been 6 times now since I've done my residency where they've predicted the death of radiology, 6 times. And the only thing that's been certain is that our field has just continued to grow. It's just continued to blossom. So this video and those comments were made in 2016, and the only thing that's happening in the U.S. right now, and I don't know what it's like in India, and I'm not sure what it's like in every other part of the world, but the volumes in radiology completely are continuing to increase. There's a shortage of radiologists. We can't find enough radiologists. So I hope they don't stop training radiologists, because right now we just can't find enough of them. So for those students, are there students here in the room here? Yeah. It's a great field to get into, you know, so anyway, just realize that the rest of the body is an accessory organ to the brain. No, I'm just kidding about that. So anyway, so I didn't want to make that in particular because of that hysteria, there was actually our major meeting, RSNA. There was actually 2 sessions devoted to it, really suggesting that they don't need radiologists anymore, and that's completely false. So I just want to make sure the students hear that, because that clearly is not panned out. So when we look at artificial intelligence, and I just pinned this just a couple of months ago, and as of February 11th, 2023, there are over 209 artificial intelligence products just when it comes to medical imaging. And this doesn't include other areas like ophthalmology, surgery, and you can fill in the blank. This is just in radiology. So as I mentioned, over 209 products. And when we talk about artificial intelligence, you have all these products. One of the things that I want to emphasize is that if I ask everyone in this room, you probably have about 50 people in the room. Again, I want to thank all of you coming. It's really an honor for all of you to come to this. Is if I ask you about your definition of artificial intelligence, you're probably going to give me 50 different answers. You know, if I ask a neuroradiologist, they're going to probably say something about stroke imaging. If I ask someone who's in administration, they may talk about some administrative issues. If I talk to a technologist, they may talk about something else. But the real thing about artificial intelligence is that it spans the whole gamut of what I refer to as the AI value stream when it comes to imaging. So we as radiologists, we always focus on how artificial intelligence can help us diagnose stroke. Can it help us diagnose a brain tumor? Can it help us diagnose tuberculosis? I know one of the big things in India right now is tuberculosis screening, so this probably comes to front of mind. But in actuality, when we talk about the value stream of radiology, it's a process. So if you look at the patient stream, the patient first comes to your department and they have to get scheduled. Once they're scheduled, they have to have the right protocol done. Then you acquire the images, then you make sure the images are transferred to your PAC system, and then eventually you have to interpret the images. So this really is this is your value stream. And artificial intelligence is actually integrated into each one of these components of your value stream. So with us as radiologists, especially I know in India there's a lot of work being done on the TV screen, and we're really looking over here and to the right. But in actuality, when we think of AI, it's going to touch each one of these processes. And so when we think of AI as a whole, it's going to be a workflow enhancer. It's going to make us more efficient. So for instance, there's a lot of work being done now on artificial intelligence for scheduling. So how does that help us? So for instance, and I think it's probably this way at AIIMS as well. It certainly is this in the United States. What we want to be able to do is have that patient show up. We know they're going to show up and then they have their study done. But all of a sudden, if they don't show up, well, we have an open slot, that's money off the table. That could be used for another patient that's been waiting for the study. So what AI actually does is that it's likely to help identify those patients that actually may not show up there for their appointment. There was some work done before that showed that the no-show rate reduced from 19.3% to 15.9%, which translated to about $180,000 of cost savings. So yes, I'm a radiologist, but I'm also an administrator, so I do appreciate numbers such as this. So just realize that AI has been used in patient scheduling. It's also been used in protocoling. So I know when I was a resident and even as a staff at large academic centers, we have to actually manually in the United States order intravenous contrast. And this takes about 6% of our work time. And we've identified artificial intelligence tool that has a 95% accuracy to automatically assign a specific CT or MRI protocol based on a deep learning natural language processing algorithm. Now, when it comes to actual image acquisition, again, when we look at the value streams, we talked about scheduling, we talked about protocoling, and now we're talking about acquiring the images. So what's another big area is the currency when we look at CT or when we look at MR, but especially of MR, is that signal to noise ratio. So if we have the ability to get more signal to noise, we can use that arithmetic and manipulate in different ways. So for instance, if I have more signal to noise, and the easiest way we do this is when we increase our field strength. So if you have a 1.5 Tesla and you get a 3 Tesla, you're going to have a lot more signal to noise. Well, you can either use that to make those images look like a 1.5 Tesla unit and get more patients going through, or you can take that additional signal to noise and really make your images look pristine. So that's the way we've sort of traditionally done it. But what we're seeing right now is that there are a lot of artificial intelligence programs that, without changing the hardware of your system, actually allow you to reduce the time of acquisition and maintaining your quality. So this helps in a couple of ways, especially if you have older units. So if you have an older unit that's maybe 20, 25 years old and you want to purchase a brand new unit, there are now algorithms that allow us to take that same magnet and actually do things quicker. So it's essentially increasing that signal to noise. And again, you can do that to make your images look better, or you can do it to put more patients through the system. So algorithms such as this is a flare sequence, and you can see that the time was 1 minute and 39 seconds, and after the algorithm is 43 seconds. So this was a 56% reduction in time. This was 1 minute and 53 seconds. It went down to 43 seconds, a 62% reduction in time. And for PET, it went from 12 minutes to 3 minutes, and that was a 75% reduction in time. So these post-processing algorithms are now being provided by independent vendors, by independent companies, but they're also now starting to be integrated into your unit. So some of the strategies that you can do is that you can provide these individual acquisitions like this and reduce your time, or you can actually take one big sequence and then parse it out, as is seen here. So you take one individual sequence, and then you can come up with your individual different sequences like FLAIR, T2, so on and so forth. So these are all different strategies that are helping us be more efficient when we actually acquire our acquisition. So the challenge is that how does this really integrate in what we do? So by the way, I'm going to be mentioning some companies in this. Just realize I have no financial affiliation with any of these companies. I just do it because the way I learn is by talking to different companies and different vendors and different people. So I just want to make sure that you understand that I have no financial relationship with any of these. So one thing to think about if you start doing these types of integration is that you really have to make sure that you can actually push more patients through. Because oftentimes what happens, you'll reduce your sequence time, but then it takes a while to get the patient on the table. You have to start the IV contrast, and you have to get them on the table. So you have to make sure that if you are going to invest in something like this, you're actually been able to put more patients through. So for instance, we looked at one of these types of algorithms in our practice, but we opted not to do it. Why? Because we would have to pay for each one of these times we put the patients in, and we really didn't see a tangible increase in the throughput. So when you are evaluating these types of algorithms, you have to make sure it's actually going to result in more patients coming through the system. The other thing that's going on right now was that this type of process was initially created by independent companies. But right now, the original equipment manufacturers like Philips and Siemens and GE and Canon and so on and so forth, they're now integrating this type of post-processing directly into their magnets. So if you are in the market of purchasing new magnets, it's really important that you ask the question, do you have some type of artificial intelligence post-processing to actually improve your throughput? So important question to ask, because that's now being integrated into your systems. The next thing that's been getting a lot of press are the various workflow enhancements. So typically, and again, I don't know what it's like here at AIIMS, but I know in our practice and in other practices, things are pretty darn busy. And especially when you're dealing with large teleradiology companies in the United States. So we have companies like RadNet, Rad Partners, Envision, so on and so forth. Literally, you can have thousands of patients on your work list. And so the issue is, how can you make sure that you can prioritize those patients that actually have an acute abnormality? Because what you don't want to do is that you don't want to have a patient that's been on the work list for 2 days, and then you found out, oh, they have a stroke, or they have a brain tumor, or something like that. That really makes it bad for everyone. I'm sure we've all seen this. You know, eventually what we do is we rely on our technologists. We hope we have good technologists. They see something bad, and then they call us and say, hey, you know, can you take a look at this? But in light of that, what's been now happening is that there are various types of initial screening by using artificial intelligence algorithms that identify those patients that have some type of abnormal pathology. So if you have a big work list on the right, these screening tests can identify maybe there's some edema, maybe there's something in the brain, and what it does, it flags them, and then it moves them to the top of the list. And as a result, there's been documentation in numerous centers that this helps you identify those patients that have acute abnormality. So this type of workflow prioritization has actually been used by a lot of the large teleradiology companies in the United States. So this was a company, AIDoc. Again, I have no financial affiliation. This was actually published in Radiology Business a couple years ago, that they've now formed an alliance with RAD Partners. So RAD Partners in the United States interprets approximately 1 out of 10 of imaging studies performed in the US. And you can imagine they have a huge, huge work list. And this type of work list prioritization based on identifying an abnormality is now integrated into their system. And I know there's an Indian company too, I think it's Cure AI, I believe. They now have a partnership that I believe that they're developing, I believe with RadNet. So these partnerships are starting to develop. And in the company that I have the good fortune of being, half of me is in academics, half of me is in community, half of me is in corporate medicine, and half of me is public policy. So that's a lot of halves of me, right? But this was one company that I was with Envision, and we did our own partnership with AIDoc. And just to give you some real life examples, what it did demonstrate was when we did use this type of algorithm where we put this into the system, it actually reduced by about 8.4 seconds our ability to identify positive studies. So it does have some benefit. But the challenge that you're going to have to determine is this really worth the return on investments to put all of these studies through an algorithm? That's really when it gets into some of the business planning that we'll talk about later. So the next thing that we'll talk about really is where we as radiologists and we as clinicians is the diagnostic utility. So for me, I'll be talking about radiology, but to be honest with you, the people that really led this were the ophthalmologists. So the ophthalmologists were able to develop, they actually had the first CPT billing code in the United States that was an actual billing code, and that was based on their ability to look for diabetic retinopathy. And that was quite fascinating because the reason, I don't know if there are any ophthalmologists in the room or not, but what was very fascinating about that was, I have a lot of friends that are ophthalmologists. I don't know, I just have this bevy of friends that are ophthalmologists. I have no friends that are like, I don't know. My wife's a pediatrician, and she's sort of my friend. I'm not quite sure about that. That's a joke, by the way. Is that, I have to tell her that, don't you? This is being live streamed, right? So, but the thing that was interesting about the ophthalmologist that would say is that there's no way that an ophthalmologist can see every patient with diabetes. Because remember, patients with diabetes can develop diabetic retinopathies. So you don't want to lose your vision. But then the ophthalmologist would always say, I can't see a fundoscopic examination on every patient that's diabetic. So what they ended up doing was developing an AI algorithm that actually looked for diabetic retinopathy. So in a way, it actually made sense. It helped the workflow. In the United States, you actually have pay-per-performance measures, and one of those is diabetic retinopathy. So that's why you could see the whole value stream was actually tailored very nicely to ophthalmology. So for us in radiology, we have been very savvy, if you will. Like I said, there's over 206 companies right now that actually have AI products for medical imaging. And one of the things that we look for are things such as this. So this is the classic example of a patient that has a very, very small hemorrhage here that's located in the cerebral cortex. Very, very tiny, it's hard to see. And so I think in a bad day, I could easily miss this, but the AI algorithm was very helpful. But just realize that this is a basic algorithm of, is it normal or is it abnormal? This is that triage I was talking about. So these workflow prioritizations, they will see this abnormality and they'll bump it to the top of your list. And when you look at the ROC curve, it's actually better, in this case, better than a second-year Mass General resident, which is probably the same as a staff member. Don't tell them I said that. But in general, second-year residents that are really good are as good as any staff. We sort of all know that, but we don't want to talk about it. But they're pretty good for normal versus abnormal. So this algorithm was felt to work pretty well. But the challenge that's happened, and why isn't this been adopted by every single practice in the United States, is that there have been over 2,000 articles that have been written when you combine radiology and artificial intelligence, over 2,000. But only 2% of the articles on artificial intelligence actually discuss the clinical practice. And the FDA, when they were pushing AI through, realized that there was a huge tailwind for artificial intelligence. There was so much momentum to try to get these companies through that they allowed validation on very, very small data sets. So you had these companies that a lot of these had private equity funding. The investors wanted to make a lot of money. So they were like, let's push our product. So all they had to do was really demonstrate equivalencies. And as you'll see there, that really hasn't translated into real world results. And some of these papers, quite frankly, were opinions versus actual implementations. And so with this structure moving on, eventually the bottom had to fall out. And these are just a couple of examples that really illustrate some of the challenges that we're facing in the US. In fact, when I talk to different chairs and system heads, I'm quite amazed at how little AI has been integrated into practice, especially in the community. So if you do talk to people that are developing AI, if you talk to my friends in the Harvard system or the UCSF system, they're developing the product and they're testing in their universities. But then on the other hand, when you go to more hybrid programs, you'll see it just hasn't had the uptake. And part of it is that you've had papers like this come out. So this was published in March of 2021 that said machine learning for health compared poorly to other areas regarding reproducibility. And this was kind of an interesting thing here as well, because about 5 years ago, I should say 4 years ago, I was at a meeting and they said 75% of the data sets that were used to train AI algorithms were either from San Francisco or Boston. So basically the Harvard system was throwing in all their data sets, San Francisco was throwing all their data sets, and they were getting very little information from the rest of the country. And so this was a paper that came out in 2021 that said, our review finds that none of the models identified are of potential clinical use due to methodological flaws or underlying biases. This is a major weakness given the urgency with which validated COVID-19 models are needed. So remember the whole time of COVID, and we know imaging played a major role in COVID, and as a result, they had a lot of algorithms to try to detect COVID based on CT. But you could see, although they were approved by the FDA, they never really had a lot of traction. So these are just some of the challenges that we've been seeing that so you need to know about. So this is an example where the AI algorithm actually identified a hemorrhage. But basically, this is just artifact from beam hardening because the skull's right next to it. And this is an example of a hemorrhage that was not picked up by the AI algorithm. So just realize nothing is 100%. Now, once these algorithms started getting into clinical practice, we started noticing a big discrepancy. So this was an algorithm that looked at automated analysis for vertebral fractures. So when we looked at this, the way it works in the US and the way the FDA works, the Food and Drug Administration, is that their goal is to not validate the accuracy that's provided by different companies that are trying to get their AI algorithms approved. Their job is to ensure, number one, that whatever algorithm is there, if the company says that it's equivalent to a human, well, that's okay for them. But more importantly, they want to make sure it doesn't harm patients. So long as an algorithm, it's hard for a real computer to harm someone. And so long as the data is equivalent to a human assessment, then that's good enough for the FDA. So this product was actually had FDA clearance, and when it was cleared by the FDA, it had a 92% sensitivity and an 89% specificity. That's pretty good, right? This is what the company actually suggested. But when they actually looked at the real world, and this was published in the AJNR, American Journal of Neuroradiology in 2021, the sensitivity was 55%. And I'm not a statistician, but I think this is a lot lower than that, if I recall. And the positive predictive value was only 39%. So the challenge here is that we're not seeing the real world application. And I think even more important for this, and I'm not sure where you are in your journey of artificial intelligence, where you're going to be creating this on your own or you're going to be buying off-the-shelf products. But I strongly encourage you is that if you do this, make sure that when you have your contracts with the vendors, you take the time to actually assess your results. What's been fascinating to me is that a lot of these companies and universities are getting the AI algorithms, but they're not testing it to see if it actually met the deliverables that were promised by the company. So the only thing worse for me than spending money is wasting money. So you don't want to waste the money. So make sure that if you do move in this manner, that you have codicils and fallbacks in your contracts that allow you to go back to the company and say, you know, your promised results are not what we're seeing in real life. So why is this the case? What exactly happened? Well, as I mentioned before, 510 clearance just means the product is safe, and it doesn't mean that it will work optimally with your system. And AI underperforms outside the training environment. Now think about this. As I mentioned before, a lot of these studies are being done at single institutions. So some are being done, and specifically at large institutions on the East Coast or the West Coast, and if they're lucky, they can collaborate with another university. But in the United States, there's a lot of guardrails regarding patient privacy. Trying to transfer data from one university to another university can be really, really hard to do. So as a result, these are performed in a very, very tight ecosystem that oftentimes has the best equipment, the best software engineers, and the technology is completely integrated within that university system. So what happens when you get out in the real world? Well, you have a lot of equipment variation. What I defined earlier is referred to as overfitting, where you your system is too tight, where you really can't consider variability. I don't know about you, but in the United States, where I work at, we have about 30 magnets, and each magnet is a different field strength, it's a different platform, it's a different types of acquisitions. So these differences in acquisition make it very, very difficult. There's clearly a demographic bias, like I talked about before. There's cultural variation. There's IT integration. Each one of your systems in your universities are a little bit different. I mean, think about it. You have a RIS system, an RIS system, you have a PAC system, and now you're trying to throw widgets on top of this for AI. It's very, very difficult to try to integrate everything. And also one thing about artificial intelligence, and again, if you are going to be purchasing these things, just realize, at least in the United States, and again, I don't know if India is governed by an FDA-like body, but when a company sells you a product, they have to go through the FDA and they have to say, this is the sensitivity and specificity. Now, artificial intelligence, by definition, is constantly learning. So as it has more data, it's constantly refining its ability to increase its accuracy. But unfortunately, if you purchase a system in 2017, the next release may not be in 2022. So all of a sudden in 2021, you're running on 2017 data. What you want to be able to do is, as soon as something's updated, you want to be able to implement that day so you can take better care of your patients. But unfortunately, that's not the way it works out. In the United States, you end up having the company has to then submit their claims for that specific software, and then they do it as a release. So if you are going to be getting into artificial intelligence and you are going to be purchasing some things, just make sure you work with your companies to make sure when these refreshes are going to come in. Is it going to be daily? Is it going to be monthly? Or do you have to buy the release? Do you have to pay for the release? Or are you under an evergreen contract? So automatically you get the releases. So just realize those are all little things that you have to worry about as well. So when it comes to artificial intelligence, the real promise was something like this. And this is the concept of upskilling. So what I talked about before was hemorrhage, no hemorrhage, fracture, no fracture, right? These are the triage things that can move things on your workflow priorities. But what we wanted to do was actually upskill people. So what I mean by that is, I know in the United States, we do have large centers, and I'm a neuroradiologist. I do 70% head and neck radiology, so I'm lucky with what I do. But if you look at the overall practice, you really have good radiologists that will do a fellowship in one area, but the group may not be big enough to have a subspecialist read every subspecialty studies. And I'm not sure what it's like in India, but in the United States, we don't have that luxury. So what we can do now is this whole concept of a virtual fellow. So the promise with artificial intelligence has always been, hey, if we can create an algorithm and we can somehow say, yes, not only is it normal or abnormal, but if it's abnormal, there's a stroke, can there be an epidural hematoma? Can there be a glioma? Is it a hypertensive hemorrhage? Is it an abscess? Is it a subdural hematoma? Similarly, for musculoskeletal, is it an infection? Is it a fracture? Is it a tumor? What type of tumor it is? So on and so forth. Well, unfortunately, we heard a lot of this about 3 years ago, but in actuality, we just do not have the capability right now in the real world to have any algorithm that's going to give us this level of specificity when there is some type of abnormality. Now, what we have seen is in the area of stroke. So I know AIIMS has a fabulous stroke unit. I know I was talking with my colleague a little bit earlier. It's incredibly busy. And I think you have been using various types of AI algorithms for this. So, if you are the person in your practice, if you're not trained in neuroradiology, but you happen to be the unlucky one that's in the middle of the night and all of a sudden you have a stroke patient come in, the algorithms now allow you to automatically identify aspect scores that you may not have learned about as a resident or a fellow. It allows you to actually identify large vessel occlusions, and if you see a large vessel occlusion, these are the ones that have to undergo thrombectomies. Again, this algorithm has been very helpful. And you can also look at the penumbra score. So for those of you that may not be familiar with this, if someone does come in with a stroke, yes, you want to be able to determine whether or not there is a large vessel occlusion, but you can also look actually at the brain to see whether or not there's salvageable tissue in the brain. So whether or not is it worth actually opening up that vessel and actually performing thrombolysis. And we do this by doing what we look at the mismatch. So we look at this area of infarcted tissue versus this area of tissue that just has reduced blood flow. And we do a ratio. We do this ratio of green, the volume in the green over the volume in the pink. And this gives us our mismatch ratio. So these are very complex functions, but are now automated when it comes to artificial intelligence. So when we actually look at the AI value proposition, we have data. Data becomes information. Information becomes knowledge. Knowledge becomes decisions. And then the decisions eventually have to change your outcomes. This is the things that we talk about when we're trying to make decisions about artificial intelligence. And eventually, when we look at the outcomes, what's that outcome going to be? Is it improving the quality of your patient? Is it improving your efficiency? Or is it financial? Are you going to be able to make more money from this? That's basically the grassroots of this. So at least in the United States, we talked about some of the challenges about why AI hasn't been disseminated. Part of the fact is there's this discrepancy between what is reported to the FDA and what's in the real world. That's part of it. We talked about the challenges with technology, but in the US, because of our complex healthcare system, we always have to ask this question. Who will pay for artificial intelligence? Something we always have to ask about. I don't know if you ask these questions in India or not at AIIMS, but sometimes we have to ask these things in the US. So what's happened in the US is that there has been a recognition that some of these algorithms are clearly beneficial. So what I just showed about the stroke, when I showed the large vessel occlusion and then I showed the penumbra and the mismatch, the government actually did identify benefits for this. So if you are a hospital-based system, so if you have a hospital and you have a stroke center, then what the government did do is that they did do this new payment program, which is called a new technology add-on payment. And essentially what this does is that if you, the hospital, end up purchasing the Viz.ai or Rapid, or you can fill in the blank, they can pay up to $1,040 facility fee for each time you use this. So this is a recognition now. It doesn't go to the radiologist, but it goes to the facility. And this was something that was just recently passed on June 28th of 2022. One of the big things that we also see are pulmonary nodules. So look, I look at the top half of the chest when I look at an XCT. I try to close my eyes once I get below the clavicles because I don't like to look at the lungs. But I sort of have to force myself to look at the lungs. So I do know what a pulmonary nodule is, and that's about it. But on the other hand, when you look at pulmonary nodules, you know they could be caused by tumors, they could be caused by tuberculosis, they could be caused by hamartomas, so on and so forth. So this company, Optellum, was recently awarded also a new TAP payment, because what this does is actually helps characterize the pulmonary nodule. And in theory, it can help you determine whether it's benign or malignant. So as a result, you may avoid biopsies, you may avoid having to PET CTs, so on and so forth. So if you're a system that has this, then you can now qualify for a $600 or $700 payment that goes to the system itself. But what about us, the radiologists? So in the United States, we have two types of payments. You have a payment that goes to the hospital, and then you have a payment that goes to the radiologist. So what I talked about before was the payment that went to the hospital. Well, what about us? You know, we're the ones that are reading it. We're the ones that are, no one really sues a computer, but they'll sue a physician, right? They'll sue us, right? So what do we get for actually using these algorithms? Well, the government came off with these various billing codes. But the thing about these billing codes, the bad thing is there are a bunch of T's right here. And those T's mean temporary codes. So when you have a T behind a code, that means we as a radiologist don't get paid anything for reading it. So it's a tracking code. So what the government wants to do is to make sure that there is actually value in this code and we're not overutilizing it. And when they go back and actually do the real value of artificial intelligence, they can track that code. So the bottom line is, for artificial intelligence right now, as a physician, we don't get paid a single penny more than we did if we didn't use the algorithm. But the government is supporting some type of AI at the system level, specifically right now for stroke and characterization of lung nodules. So the last thing that I'll talk about is where I think AI is going to be going from a real practical standpoint. So there were a couple of articles that came out about 5 years ago. Actually, it's 2023, so 4 years ago. And this was a very interesting article that looked at specifically lung cancer screening. These were from our friends with Google. So what they did was actually, for me, kind of interesting. Have you heard of the lung cancer screening trials? Have you heard of the lung cancer screening? Yes? Okay. So do you have that in India right now? Yes, sort of. So what it does, in lung cancer screening, what happens is that if you have a patient that has an over 30 pack year of history and they have the wrong demographics, they are at risk for developing lung cancer. But in the US, we actually have a specific program in which we take these at-risk patients and you perform a standardized CT. So that's part of the National Lung Cancer Screening Program, and it's put into a database. So what Google did is they actually worked with the National Lung Cancer Screening Database, and they had over 42,290 chest CTs. And what they did is they put this through a deep learning algorithm, and what they found was that this actually decreased the false positive by 11% and decreased the false negatives by 5%. And so if you're a non-thoracic, if you're a radiologist that's never done a cardiopulmonary fellowship, which I assume is the majority of people looking at these, this is the concept of upskilling. And this algorithm actually helped increase the return, the ROC curve, compared to non-fellowship trained radiologists. So bear with me on that. So that's one area where it's helpful. The next was mammography screening. So Google also came out with an algorithm in which they looked at mammography screening. And what they found out is that this is a study predominantly performed in the UK, so using the National Health Service, and they looked at one institution in the US, which was Northwestern. And they found that this algorithm reduced the false positive and the false negative rate, but even more importantly, look at the negative predictive value. It was almost 100%, 99.9%. So what was fascinating here is that when this article came out, the wheels start to think and then say, aha, in the UK, there's a shortage of radiologists, and each mammogram has to have 2 radiologists interpret them. It's quite possible in a disorder like breast cancer, which is low prevalence of disease overall compared to the number of mammograms that are done, it's quite possible that you could put this individually through the algorithm first. If it's negative, you still need to look at it, but realize that the study's probably going to be negative. So where we're going right now is very interesting. So this was a company called RadNet in the United States. They do about 8 million exams a year, 350 outpatient centers, and 8,500 employees. And what RadNet did very quietly is that they actually purchased 3 companies. And the interesting about these 3 companies is that Deep Health performs mammography screening, Adance is lung cancer screening, and Quantinib is prostate screening. So where this is going is that they took these companies in-house, so they don't have to look at FDA clearance. But what they decided to do was take these companies in-house because where they feel the future of artificial intelligence is through high output screening studies. So in mammography, we know in the United States, women get mammograms every 1 to 2 years, depending on, which protocol you follow. And I think that's starting to develop in India as well, too. We have the National Lung Cancer Screening Database. And I always say prostate to men is like breast in women. The thing that I always worry about is my prostate. When I always check my prostate screening every single year just to make sure that everything's okay. But where they feel the field going is that the population is going to expand. There's going to be more emphasis on screening. So if you have a software that can actually help identify properly the negative studies, and anything that's positive then can be interpreted by a radiologist, at least they feel that this is where things are going. So finally, one of the challenges of artificial intelligence as well, too, is that if you are going to get it, I'll just leave you with this, is that just realize that value is quality plus access divided by the cost. So quality access divided by cost. So we as providers, that's the term that we're using in the United States. We're radiologists and we're other physicians, but from a big picture health system, we provide care. What we want the AI to do is to increase quality, decrease cost, increase our revenue, and increase the efficiency. From a corporate standpoint, you have to be a little bit circumspect about this. And I don't want to say corporations are nefarious, but what I will say is this. Some of their missions align with us because they want to ensure their products add value and they increase efficiency. But as I said before, their goal is to make sure they can get their product FDA cleared and sell their product. And once they sell the product, the onus is on us to see whether or not it actually works or not and doesn't meet our goal. Realize that any corporation, and this is where my MBA comes in, companies have one goal. And do you know what the goal of a company is? Publicly traded company. Anybody know what that is? It's to maximize shareholder value. Okay, that's the goal of any good company, is to maximize shareholder value. They also want to maximize their private equity investments. A lot of these companies took off about 10 years ago, and so they have a lot of private equity investment. So they want to make sure they can give a good return to their PE so they can still stay in business. And then also their exit strategy. Those of us that have been in the game for a while, we know sometimes we've bought a certain company or a certain product, and then that company is acquired by a different company. And the next thing you know, that company starts not being innovated anymore. It starts to plateau. Or those relationships that we've built with our vendors and our salespeople, those people are gone. And the next thing you know, we're kind of, we're sort of left dead in the water. So we also have to look at the exit strategy of some of these companies. Are these going to be around for the long term? Or is their goal to be acquired by a bigger company, make a huge windfall, increase the private equity payout, and also increase the value of the stock so the people that bought the stock can get out? So in the back of your mind, you have to think of a little bit about that. So our challenges is that AI can be brittle. Like I say, it's inconsistent. There's bias. It needs infrastructure. There's lack of standardization and integratability. And what about those updates? But if you are going to invest in artificial intelligence, you have to ask yourself, and this is what we're faced in the US as well too, is what is the real reason we're going to buy that piece of software? You really have to ask yourself that. You know, are we going to do it to improve patient care? It depends on how you define patient care. Is it to improve diagnostic performance? You have to make sure you define diagnostic performance. Is it going to increase our efficiency? And who's really going to benefit? Is it going to increase our efficiency? We can move more patients through the emergency room. Is it going to benefit us because maybe we can be better diagnosticians? These are all questions that we have to ask. And what we are seeing right now in the United States, and I think it's disseminating throughout the world, is that we're seeing the development of an AI marketplace. So the way these marketplaces are work, it's like, you know, I grew up before the iPhone, right? So if you look at your iPhone, you know, you have these thing called apps, right? And you get these apps and you purchase it from a marketplace, right? From Apple or Android or wherever you get your things from. You don't have to develop them yourself. You don't have to go and buy it and then put it on your phone. You just go to a marketplace and you download it. So what's happening right now is that, you know, there are thousands of radiology groups, you know, across the country, and you have, like I said, hundreds of AI companies right now. How does a radiology group figure out to invest in a certain amount of artificial intelligence product, knowing that the challenge that we see? So what's happening right now is that these companies have popped up that actually provide a marketplace where you can go to that marketplace and buy your widget specifically there. So you don't have to look at 10 stroke things. You don't have to look at 10 lung cancer screening things. You don't have to look at 10 whatever. They're basically consolidators that you can then work with, and you can identify the specific apps that you want, and then hopefully that will integrate with your IT. So we're seeing this thing pop up. So this was a company, Blackford. They were recently purchased by Bayer literally about, I think, 3 months ago. And now some of the companies like GE and Siemens are developing their own marketplaces as well. So in summary, what I'll say is that about 5 years ago, there was this thing. I don't know if do you have the Marvel heroes here in India or not? You know these. I actually don't watch it. My wife watches these things. I don't know what she's doing, but she watches these things along with my kids. But about 5 years ago, the mantra was the AI is going to save the world, right? The AI is going to save the world. But in actuality is that we should be asking, will AI save the world? So is anyone familiar with this curve right here? Have you seen this curve? So this is the famous Gartner curve. So in the United States, we have a lot of consulting companies. You know, we have Gartner, we have Bain, we have a whole bunch. But Gartner came off with their famous curve. So the famous curve, as you can see, it's somewhat sinusoidal. You have a peak, and then you have a trough, and you have this flattening. So this level here is called the innovation trigger. This is when a new technology comes out. And then you have this area right here, which is called the peak of inflated peak of inflated expectations. This is also known as the hype curve. So we call it like the Gartner hype curve, but this is where all the hype is. Then what happens? Reality hits. And then you have the trough of disillusionment. And now you're saying this thing's never going to work. This is like awful. But eventually what happens, you have a slope of enlightenment, and then you have some type of productivity. So when we looked at the Gartner curve, and this was as July 2017, DL is deep learning and machine learning is right here. And this is when Jeff Hinton came out and said, you don't need any more radiologists. This is when many of our organizations even started to question the validity of its members, like myself. I mean, we support these organizations, and they were even intimating maybe they don't need enough of us anymore. So that happened in 2017. Well, last night when I was jet lagged, I said, well, I need to update my curve. So I had the 2021 in this talk, but I'd do anything, my friend here. So I updated it with the 2022 curve. And you can see here now that deep learning is now in the trough of disillusionment. And I don't know what happened to machine learning. It kind of dropped off. I don't know if it just vanished or there was an error or something like that. But if you look more, eventually we'll get through the slope of enlightenment and the plateau of productivity. But my point is that as we move forward, radiologists that actually use AI will be more productive than those that don't, and you will have a competitive advantage. But what you have to be able to do is ask those questions, understand why you're getting it, and make sure once you have it, make sure that it actually enhances your value and your overall practice. So with that, I'll stop. Thank you so much for your attention and the honor of being here.
We can have some questions from the audience in case they want to interact, please.
Thanks for a very interesting talk. One thing here you mentioned right in the beginning that if you are asked 50 people, what is the definition of AI? You get 50 answers. So we are looking forward to kind of your definition. So one is if you can tell that. What is your definition of AI? Because many companies, they come and they say that our product has AI. Now, how to kind of check and how to make sure that, it's some real decent AI or not?
Right, it's a great question. The answer that I'll give you is it really depends on the question. It's the problem that you're trying to solve. So I'll give you a little bit.
Sorry, we can hear you.
Okay. So I'll give you an example. We were approached by one of the companies regarding increase our signal to noise. So it was a post-processing algorithm where we wanted to get more signal to noise ratio. So we looked at that, and it wasn't even to improve our signal to noise. It's that we had an older fleet of magnets. So there's a certain subsection of an older fleet where it'll cost $3 million to get a new magnet. And because the government has reduced the facilities fee so much in the US, it kind of made sense that if we can have some type of add-on, we could extend the life of that magnet. So that was one question we asked ourselves regarding artificial intelligence, and our group decided not to invest in it. The two areas, the three areas where we are using AR in our practice that we're using the stroke algorithms. We're using something by a company, and again, I have no financial interest in this, but it's called Rad AI. And what's fascinating about this is I'm sure everyone's using voice recognition here. But what it actually does, it actually creates your impression for you. So if you're dictating a big, long dictation, especially spine MRs or a brain MR, or, again, I'm a neuroradiologist, I'm sure other parts of the body have long dictations like us, it actually creates your conclusions for you. So that is, in a way, a workflow enhancement. It doesn't really help my diagnostic accuracy, but it helps our workflow enhancement. And we also use AI, and this is like pseudo AI, because I showed that slide about big data. If you look at the literature real carefully, some of these products that are now claiming they're AI were around before 2017. So they really weren't AI, but what they did is they went to the FDA, they developed some type of algorithm, and now they can say, before it was company Y, now it's company Y AI. So we do use AI for some of the dimension stuff. So we do use neuroquant and lesion quant, so it's not really true artificial intelligence, but that's how we're using it. So it's a long answer to a short question, but it really depends on the question that you're trying to ask. And so that's why I wanted to make sure that, if you are thinking about it, not only as a radiologist, but in any of your practices, make sure you look at the whole value stream, because one company is going to go here that may be helpful, but realize there are other companies that will be along that whole spectrum. Yes, sir.
Yeah, excellent talk, and it's very lucid and a realistic world scenario, not hyping something. So the question which is very often asked, in health technology assessment, we have different levels from level 1 to level 5. Starting from you're talking about sensitivity, specificity, positive predictive, negative predictive, all these jargons in imaging is all only level 1. And the 5th level is societal benefit. And in between comes, is the technology preventing unnecessary surgery? Is the technology preventing unnecessary treatment? So if you pass most of the radiology imaging science, they level 1 or 2, they never cross even 3. And if we are using AI in radiology and subsequently it will be in clinical, I assume maybe another 10 years time, I'm very optimistic. In 10 years time, the patient comes with pain abdomen, the junior assistant will put all the data and they will come out, okay, send this patient for a ultrasound of the, for appendicitis.
Yeah.
So that will come, but whether appendicitis is there or not, that radiologist will be able to tell that. So what I am trying to say, investing in AI at this point of time, country like India, are we going to be benefited in early or we'll wait for the wave to settle, just like you saw the Gardner's curve where it's already in the top?
Yeah.
Just a corollary to this
Yeah,
question,
sure.
because you can club, the question was in my mind also. So if you look at our country, India is a very vast country with a rapidly growing population, which is outpacing any effort which the government does, and a lot of effort is being done. So if you look at the various generation of imaging systems that we have, the DICOM, they are not all DICOM compatible. And we have a digital health mission policy, then which is the national one. The challenge is that we can use AI and an invisible radiologist can be sitting at the back end and giving diagnosis. The stream of the number of X-rays and the images which come, Dr. Mahajan will vouch that, are coming to specialists is huge. Now he's deploying, not always, non-radiologists to interpret the middle of the road things. And the ones which are high end, they are spending time on that. That's why you said that our radiology is still necessary. So one thing is, you mentioned that you can upgrade the magnets to upgrade instead of changing the entire equipments. I don't know how costly would that be, but that's something which is very useful country like ours, because changing equipments to make them seamless for digital transmission would be a monumental task. And if we can have something of this kind, which clubs with a question, capture or display, which is more expensive? Because obviously we are interpreting data and we can put them into a software. If the capture is good enough, then the displays can be made rather more intricate with the inputs. And finally, and you mentioned all this, and I've just taken what you have said, diagnostics can be very rapid, but is it being translated into therapeutics with the same pace? We may diagnose high-end things, but at the ground level, we have therapy. I'm not saying it's wrong. It has to outpace also. They should go hand in hand. But currently, we have to redefine things in such a way that we have an index. That well, we have got we have made a diagnosis far too on the left, but therapy remains the same. So I think these are challenges, and we should, as Homo sapiens, we welcome challenges. So I think I tried to match the question so that we can holistically, you can answer this.
Well, first of all, thanks for paying attention to what I said. I've got 2 kids and a wife, and they never listen to what I say, so I'm not used to everyone listening with every word. So thank you for that. So I'll answer your first question first, and I think I have hopefully concise responses for each of those. As I mentioned before, for me, it's data is information, information is knowledge, knowledge is decisions, and decisions have to affect outcomes. That's always been my paradigm. So I completely agree with you, is that eventually the value of anything is really determined on does it change your decision making. So from an AI algorithm standpoint, it depends. The answer can be yes, and specifically, it's if the algorithm is able to detect a hemorrhage that the radiologist is not being able to pick up, then 100% it actually affects your ability to your clinical judgment and your decision tree. So it clearly can be beneficial. The other thing where it can help as well too is, and I don't know what the work lists are like here in India, and I don't know what it's like in AIIMS in particular. I think in general teleradiology groups, everyone's got long work lists. So there is a benefit for the work list prioritization. But I know when I put on my administrative hat, we always had a pinch point from the emergency room. And so, what is that? So we always had an issue from the emergency room. So we tried to, I don't know about your emergency room, I think you call it, not the ED, but we needed to get patients out of the emergency room because there was always a backlog. So if there was actually a patient that had something acute, we could then triage that patient and know they have to be admitted to the hospital, as opposed to them kind of waiting. So in that case, the decision making may not determine whether or not they go to surgery, but it does overall improve your efficiency when you look at a system process issue. So it's a different type of decision making as opposed to someone goes to the operating room or not. So I hope.
In a sense, actually, if I am very careless and I see 1,000, supposedly in a chest CT, you have to see in 2 minutes 1,000 sections, and you just go. If you see the radiologist, I know many of them. If you see in the West, so they within 1 or 2 minutes they say 1,000 is okay, normal.
Right.
But that will be if you have got CAD. So that will help you saying, okay, here in the right lower lungs, there is a nodule. I should pay attention to it. So it is helping you. It is a good servant, but cannot be a good master.
Right, 100% agree. But that gets, I was going to say, that gets the issue that the director brought up regarding this, the country as a whole. And if you look at, right now in AI, we kind of looked at the radiologist level, we looked at the department level, we looked at a single institution level. I'll tell you a little story that I think it's now applicable now is when I was at Michigan State, Google actually called me. So the first lung cancer study, they actually called us to basically do a data dump for their cases. And I remember I was talking to him, and a lot of people were into AI. And I remember I asked the person, his name is Dan Zay, and I said, what are you trying to do with this, and why do you think you can be successful? So his first answer is that we can be successful because we're Google. So there's a lot of hubris involved with it. And so, good for them. I don't mind being, I don't mind have that self-confidence as long as you can back it up, and they've clearly backed it up. But then I ask about what do they really want to do with chest x-rays? And so I know with Cure, they're doing a lot of TB testing. But what Google really wanted to do was to integrate, at that time it was just a chest x-ray algorithm, to look at low resource countries that have geographic disparities for radiologists. So the concept is that if you can develop, and this is where I fundamentally disagree with the statistics that are being used to evaluate AI. Everyone concentrates on sensitivity, specificity, positive predictive value. I think it's a negative predictive value, and that's why I was happy with what RadNet did. So if you have an algorithm that gives you a really, really high negative predictive value, then you can use that algorithm and deploy it into areas that are rural. And if it's negative, it's probably going to be negative. But it's positive. Those are the ones that can then get sent in to the large centers. And then that can be seen by a radiologist. So that actually, from a system standpoint, I think that's a real tangible benefit, especially in a place like India.
Sorry, you had mentioned about 209 AI programs which are already available for radiology. Unfortunately, it's very difficult to actually figure out who developed these programs, who was involved in, who was the gold standard in this, who was reading the actual X-ray and teaching the computer that this is right or this is wrong. So most of the times, somebody like you is too busy to be involved in this. So it's some junior member of your staff, somebody who's a fresher, somebody who's just an MBBS, who's giving them the data. And we all know from the early days of computers, the GIGO principle, garbage in, garbage out. So large part of these are pure garbage unless they're tested in real world scenarios. Now, that's not my question. My main question, which is the hype currently today is ChatGPT. Now, is that pure hype, or is that actually something which is an AI which is going to help radiologists? Yeah, I'm sure for workflow, it's fantastic. For protocoling, it's fantastic. For improving your image quality, it's fantastic. But real world clinical outcomes, which of these programs, 209 programs, have changed the outcome of the patient?
So let me just add one more thing, because to save time and to discuss things holistically, if you look at it, that when we get a particular image and you have an AI which is fed into this to interpret fast, as he very rightly mentioned, do we have concomitant input from the clinical data? The clinical input has to be integrated for an outcome which is constantly changing. And is that happening? So as I mentioned earlier also, radiologists generally have chosen themselves to be at the back end as the carriers. But with time, they have become invisible altogether. And therefore, this is a jargon I'm using from the literature actually, it's not my own concoction. And therefore, what is there among these 209 or 210th, which is going to be on around the corner, are we thinking about marrying the clinical information, adding on to the information that we have picked up from the images so that an algorithm of a different kind configures and which is more realistic? And I think that with this, you can actually club the question which has been asked.
Dr. Mukherji, if I may just intervene here. We've been, in this country, a lot of work on AI is on, and Cure.ai is one of the foremost companies in the world. We have been also involved with AI in our group for the last 5 years. We were amongst the first to choose to become a marketplace, but not just a marketplace. Currently, we have about 75 algorithms available on, and again, a disclaimer, I chair the company. It's called Carpal.ai, and out of which about 35 are US FDA approved. The concept being one, of course, that the AI interpretation, which is the holy grail, has to be as good as a radiologist, should make only those mistakes or less than what a human radiologist will make. And also, the concept of validation and pre-deployment testing, which is something which Professor alluded to, is something that is inbuilt into this, because ultimately you will have to, as was said here, garbage in, garbage out, you have to test that algorithm on your data. Right. And All India Institute data may be very different from a Safdarjung Hospital data, which is across the road. So this platform, as we call it, enables all of that. It even enables you to fine-tune the results as you want it. I want 100% sensitivity. Even if I get 5% false positives, I'm not bothered, because the negatives I'm going to probably not see, but every positive, and even if a negative is called positive, I don't mind, I'm going to look at the positive. So I think we are still in a stage of evolution. What this platform has also developed, answering Professor's question regarding whether clinical data can be fed in, as yet that is not possible. I'm sure as computing power improves and the methodology improves, even that will happen. But as yet, it is all based on the image. What has been done here at Carpal.ai is that 2 or 3 algorithms are fed in together, and the X-ray chest or the head CT is read by all 3 of them. When all 3 of them say it is normal, then one believes, and this is a deep dive that we are still doing, that it is normal and a human radiologist may not see it, because that's the ultimate goal. When it says that there is something positive in even 1 out of those 3, then a human radiologist will look at it. So we are still at an evolutionary stage. I think the hype cycle is over. We are probably just above the trough. If you see between last year and this year, there has been a little increase, and ultimately every institution, every diagnostic center will have to test on their own data. And then ultimately, I believe 150 to 200 algorithms will come into use from different vendors, whether it will be the 10 top vendors who will have these 200, or it will be 100, we don't know. That time will tell. But no institution is going to talk to 100 different vendors. And that's where the marketplace approach, where you choose what you want to use, and when you use it, you pay for it. And also IT integration. I think India has taken a leap. I'm on that government committee. And I think India has been very forward-looking, where we are trying to, across the entire public as well as private healthcare system have one engine, one skeleton through which all the data will run. This is really futuristic. And so one institution will have one pipeline through which you have host of AI algorithms. If you determine that the one you have doesn't work well, you don't need to again do a whole integration process, which can take up to 6 months. So I think after the hype of the last 6-7 years, we've come to reality, and now slowly we will reach deployment. As regards the the scanning itself, and as has been said by Professor Mukherji, that's something which is very useful. Your old machine requires just an add-on box, and you will get much better image quality. Maybe a 1.5 Tesla machine producing 3 Tesla like image quality, and a 3 Tesla machine producing a 7 Tesla like image quality. These are products that are currently available and used in many parts of the world. But the interpretation part is where all the question marks are, and that actually is where probably you alluded to what sense will it make to a healthcare system? Can we reduce cost for the patients? Can we improve profitability for the healthcare system? That actually will determine ultimately whether it comes into use or not.
Yeah, that's great. I did want to make one comment. First of all, thanks. It's great. It's great comments. I did want to make one comment about the radiologist being invisible. So I completely agree with that to a certain extent. I mean, at least for the students out there as well too. For me, the radiologist was almost like the Wizard of Oz. So, you have this person that you never see making these incredible diagnoses with the latest technology, and it just sort of appears. And I think that model is still valid if you're at a tertiary or quaternary institution where things are very, very busy and you have a lot of complex cases. But what I've seen in the United States, again, part of it is just the different roles I have, is in the United States, as I mentioned, value is cost plus it's quality plus access divided by cost. So you can have the best quality system at the lowest cost, but if you don't provide access to healthcare, you have zero value. Zero. So what we're seeing now is a renewed emphasis on access to healthcare within the U.S. And oftentimes that access is not being provided by physicians, it's being provided by physician extenders, it's being provided by nurse practitioners, et cetera. And they're the ones that are actually ordering the imaging studies. So from their standpoint, with the volumes going up and a higher percentage of physician extenders ordering studies, I actually think the radiologists are playing an even more important role. Because if you have a physician extender or nurse practitioner, what they want to know is there something acute where I need to refer it to the hospital, or is there something non-acute where I can handle this in my own practice? And this has actually, at least in my opinion, pushed radiology to more of a front line because they really are reliant on us for that initial triage. So I'll stop there. I do have a comment on ChatGPT too, because my daughter's a software engineer, and before I came to India, I was talking with her and her boyfriend, who's a genius, and they were telling me all about ChatGPT. But I can answer that, or I can wait for the next question. It's up to you guys.
Professor Mukherjee, I had a quick question, 2 quick questions actually. So thank you for the wonderful talk. One is I just wanted to check when you speak to a vendor who has an AI solution, how much information about the training process, the model, how they train their model, the network details or the training data, do you actually make it imperative for them to really tell you about? Because we know it has a lot of implication on how it's going to perform in the real world. And the second one was just a comment actually more than a question, but as far as the question on the clinical integration, so in our lab, we work a lot on mammography AI and lung AI for nodules. We have actually sort of done many experiments where we've integrated, for example, the clinical examination findings into the it processing the image, as well as information from the labs, particularly so we're doing it on lung sarcoma nodules. So I think, perhaps that's possible and something we'd see.
Yeah, 100%. I think that's the latter. I feel more comfortable in the sense that's almost like a neural network approach where you basically have different inputs, and 100% that gets to the comments that were made on the left side. So, when it comes to artificial intelligence, in general we sort of default to machine learning and deep learning and convolutional neural networks, but I don't have it. I have it actually in a different talk where it tells you how much of a lack of a visionary I am. We actually published a paper in 2001 on multiparametric spectroscopy using a neural network, but I wasn't smart enough to call it artificial intelligence at the time. And then I go back and I'm like, well, now you're looking at multiple parameters and you're using a statistical modifier and basically doing some type of risk stratification and putting it into the neural network, and that's what you're talking about. So I 100% agree with you, and that's in a way sort of been the holy grail. The issue is how do you find the right data, make it relevant, and then put it into those classifiers. So congratulations on your work.
Just a short question.
Oh, well, I was just going to say, the questions that you asked the vendors, that's a real tough one. I think when I talk to the vendors, I always get the same response. Ours is the best. We've had the best people looking at it. They throw out some great academic institution they've done. It's been iterative, great. I think the back end is more important, and ask them about when's the refreshes coming in. What if it doesn't work? What type of guardrails do I have where if the results that you're promising don't actually occur in my system? That way you can sort of get to the same thing on the back end. It's like, for me, I would never buy a car if I didn't have a good warranty on the car. So that's the tactics, that's the approach I would take. I'm sorry, I didn't mean to cut you off. Yeah.
As a pediatric surgeon in radiology, we are concerned about the methodology in which the radiology is done, especially in contrast studies, the method that has been adopted. Because if the method is not right, the position of the patient is not right, or the correct amount of contrast has not been given, then the results are not as per the mark. So can AI help in that? You said you can protocolize our methodology?
Yeah, I think it can help with some standardization. I think when you're at a place like AIIMS where you have the best and the brightest, I mean that with all sincerity, the best and the brightest people here, you're not going to run into those issues. I think once you maybe get out into the more rural areas where there's more variability, I think that's where the real benefit of some of the AI when it came to scheduling and protocoling comes through. That really is more of a simple test. It's basically look at a keyword lexicon, and where you can help with that is to standardize the nomenclature that you use when you do put in your orders. I know from my standpoint, when I'm a human AI, when someone calls me up and say, why did you do this? And I go back and look at the report, sometimes it's my error. But sometimes I gently point out, well, you didn't mention that in your history. So I think moving forward, I would work with your partners in radiology to make sure that you can standardize the lexicon that you're using. And once you have the lexicon,
when films from outside are read, suppose an AI machine is reading a film, is there an AI system that tells whether the study is done properly or not?
Oh, that's a good question. I don't know if it's done on the back end or not. The protocol that I had was more on the front end, but from the back end, I'm not aware of that one.
Thank you very much. I think let it not be the last answer in the hall. There'll be more question and answers. You can dialogue outside when we have a cup of tea. So thank you very much. Despite the jet lag, I mean, you are like as fresh as anybody. Thank you for coming all the way, giving a wonderful talk, stimulating all of us. And obviously, we'll continue our chat outside. Any other question do you have? Okay, then we'll honor him by a plaque. Yeah.
Oh my.
We both together, we can give it. You come in the center. Thank you for coming. Congratulations. Such a pleasure. We'll hear you more in the next 50 days.
Thank you, sir. Thank you for staying the whole time.
You all can join us for the cup of tea outside, please.